Yo, what up? It's a tip of the week, and today we're going to discuss how to prepare a site for an implant. Alright guys, so if you're new to this channel, I'm Dr. Jared Williams. I'm a concierge dental surgeon in Houston, Texas, and I work with about 30 different offices providing oral surgery, implants, and also IV sedation. I also do coaching as well in office on site. And the reason why I created this channel is because after so many years of practicing, I realized I'm getting great results. But I believe that in order for dentistry as a whole to be impacted, let me share these results with you. So after 10,000 cases, I think I've figured out a couple of little pearls, and hopefully you'll take some if you're smart. All right guys, so if you're new to this channel, hit the like button, smash subscribe, and also if you want more tips, more free tips that is, go to smileaftersurgery.com. Guys, if you have an issue getting your patients numb at any time, don't fear, never fret. I have a book on there that is 100% free that you're able to learn how I get all my patients numb. I don't care if they're 12 to 112. Doesn't matter the comorbidities, I got you covered. So if you're stressing yourself out, look no further. Go down to the link. After you press subscribe and like and share with your friends, hit that link and I got something special for you. All right, so if you're ready, sit back and relax, and I think I got something special for you guys. All right. Alright, so I'm going to show you this case. I'm going to throw it up here and I want you to just take a look at it. So if you look at this tooth, there's two sites in specifically I'm working on. The top right is going to have a tooth not present, and then there's one on the top left. It's a premolar. It looks as if the tooth has caries to it and it needs to be removed. So if you're going to be working on this case, a couple of things that you're going to have to take into consideration. Number one is this. Atraumatic extractions are the route to go. So if it takes you about 45 minutes to an hour to atraumatically remove this tooth, then that's what you're going to do. Now, if you follow this channel, you shouldn't be taking 45 minutes to take out any tooth. Well, let's just say this, a small fraction, maybe about 5 to 10% of the cases. But if you're following this channel, I show you how to take care of these teeth in record time to where you could place an implant. But that's neither here nor there. But let's get into it. All right, so if you're looking at this case, it is, let's just say it's the upper left premolar, which is going to be tooth number 13. And as I'm looking at it, I want you to just take a look at it yourself, and I'm going to hover over it. And so what I want you to do is this. I want you to take into consideration, how are we going to prepare this? Well, what we're going to do is this. We want to make sure that we keep the buccal plate. I don't care how good your technique is. If you don't keep the buccal plate and you're wanting to place an implant, you can forget about it. Now, I know there's different advances in which you can graft and augment the site, but if you don't keep the buccal plate, it's going to be very challenging. You know, if you haven't taken out a lot of teeth, just to kind of give you an idea, the buccal plate is probably about the width of your fingertip, right? So if you were to just put your finger nail in between the other one, that'll kind of give you an idea on how thin the buccal plate is on certain teeth. And after observing that, as a matter of fact, if you go to a CT scan and you just check out a few CT scans, it'll sometimes look as if the roots are sitting outside of the buccal cortex, the buccal cortical plate. And when that happens, it's like, huh? How is that possible? But the way in which the creator created us, he had a wonderful way of doing it. And I don't ask questions, I just try to respect it. And that's how I'm able to get results. So the main thing is this, is make sure that you keep the buccal plate intact, because when you don't keep the buccal plate intact, what literally happens is you have a traumatic extraction. And already speaking, if you go all the way back to your gross anatomy days or just some of your anatomy days, you know that, or dental anatomy, you know that the buccal plate is going to go in and up. All right, so in and up. So if you take that in consideration, if you take out that buccal plate, that just lets you know it's less space or less movement that's going to be moving in and up. And if you need to place an implant, because that's the whole purpose of this tip, you want to make sure that you have the implant circumferentially surrounded by bone. I used to teach in the course that I have about 2 to 2 millimeters, but now I'd say let's bump it up to 3, just so that you make sure that when there's dieback from the bone or the bone starts receding, then you're able to be comfortable and sleep peacefully at night, because that's how you smile after surgery. It's not just doing the case and then going about your day, getting on your yacht or your boat or doing whatever you're doing post-COVID once all this foolishness ends. But what you're gonna have to do is be aware that as you are maintaining that buccal plate, you want to make sure that that implant is circumferentially surrounded in bone. And that's how you're going to be preparing the site for an implant. All right. So that's number 1. Number 2 is this. Since you're going to be taking out this tooth, what you're then going to want to do is pack the socket tightly with bone. I remember I was sitting in a lecture, CE, and one of the oral surgeons that we were learning from, he was teaching about how to place molar size implants. And I love molar size implants. Molar size implants can be like almost the size of your thumb. They could be about up to 10 millimeters wide, and you can go up to 13 millimeters long depending on the implants that you're working with. So it's kind of like almost a finger. But if you place enough implants or take enough teeth, you could sometimes recognize how a molar size implant would be great for a molar size. So when he was lecturing, there was a question I always had. I was just like, how much bone do you pit? Because when I first got started, bone could be somewhat expensive. And if you follow my channel, especially on Instagram, follow me on Instagram, by the way. But if you follow my channel on Instagram, I talked about at one time about, not being cheap. And so, after going to several offices over these last decade or so, I've seen a lot. And because I'm not paid for consulting when I'm going into these offices, I look at some of the things that some of the doctors are doing. And even myself earlier on in my career, like right when I got out of residency, I was realizing like, man, I didn't feel quite as comfortable. And so the question I asked, that I paid like thousands of dollars for, you're getting it here for free. And that question was this, is like, how much bone are you supposed to put in the site? And the doctor gave me great insight at that point. So what happened was, he told me, he was just like, whatever bone that you use, make sure you pack it so tight that you cannot put anything else in the site. I've seen some doctors put just like a half cc in like a molar site and then suture it up and let them go. But just like, that's not gonna work. Like, you're probably gonna need like a whole cc, maybe a cc and a half, to fill that site, to where when you press on it, it's kind of like cement. Like, you're pressing on it and nothing's giving. Like, I mean, I'm literally putting like a lot of force when I'm packing in that bone, because I want to make sure that once a tooth is out, once the sites have been debrided, once I've really irrigated the area and I start packing that bone in, I don't want those buccal plates to be manipulated by the tissue or just the way in which there's natural resorption. So you really want to take that in consideration as you are preparing the site for an implant, specifically a immediate implant or a delayed site, which you graft the area and come back in about 4 to 6 months, or even longer depending on the case, and you're able to place that implant in there. So just keep that in mind. Now I'm gonna share with you something that was always eluding me at one point, and that was, how do you know if the bone is actually gonna grow? All right, so I'm gonna put up this graphic here, and it talks about osteoconduction, osteogenesis, and osteoinduction. So conduction, genesis, and induction. All right, so this was something that used to elude me for years, but I was just like, you know what, let me just kind of think this thing through and try to figure this thing out. And so what happened was this, one day I was looking and I was like, conduction, what does that mean? So conduction is basically, you want to form a scaffold, kind of like a box, right? You want to have something that the bone can be a part of. That's why it's so important that we use membrane, so that the tissues don't go and invaginate the space. And if they invaginate the space, then it's going to not allow bone to actually fill in. And so you want to have something that will create a scaffold, right? So we can build upon. The next thing we want to have is osteogenesis. The genesis means the beginning or the birth or something along those lines. And so something that could actually have the cells to grow, all right? So you have a scaffold, and then you have bone cells that are going to grow. And then once you have those two things, then the next thing you want to have is induction. That's where we take those baby cells and we have them create osteoclasts and osteoblasts. Osteoblasts are bone building, clasts are bone chewing. I remember I was sitting in one of my biology professors, and he was just like, was a young lady chewing gum in class, and he was just like, Kelly, because that was her name. She was like, Kelly, you're chewing in class. And so everybody was just like, huh? They were like, you're never going to forget that. So osteoclast is where you're chewing. So the bone is actually chewing up other bone to form more cell and haversian canals, and basically blah, 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 all the different things to actually create bone formation. So you need those three things: osteoconduction, genesis, and induction. Now, the gold standard is going to be autogenous. I had to think about that for a second. Autogenous, and that's basically where the bone is going to come from the actual individual. Then you have alloderm and different bones. And so one thing I wanted to make sure that you're aware of is making sure that whatever you do that you put in that site, make sure it has all three of those things. So if you could get autogenous bone where you could like scrape it from a different site, put it in there, do that. But just want to make sure that when you are operating, if you're going to prepare the site correctly, autogenous bone is a gold standard. All right, guys. So there you have it. Let me see if there's something else in my notes that I wanted to share with you. Another thing that you want to also look in, this is something that I never really paid attention to, and that was calcium phosphate cements. All right, so guys, I used to laugh at other doctors or individuals, especially reps who would bring these putties and cements, and I was like, what kind of bull crap is this? Like cement, bone cement? This is crap. Well, I actually did the research on it, and as a matter of fact, there's about 40% bone loss, 42% bone turnover than when you were to put any other type of bone. Once again, autogenous bone is the better aspect of it, but if you want a significant high turnover of bone, calcium phosphates, cements and putties, those are really good because they look like it's just like putty. It kind of looks like you are mixing up plaster, and hence some of the similar things that it's in. But just keep that in mind, because don't use plaster. I'm not telling you to do that. But what I want you to do is just take that in consideration. Do some research on it. It is phenomenal in a sense, because I found that when I would use other type of bone grafting materials, I would notice that when I come back in about 4 to 5 months, I would get very, very, very soft bone in there. And that's just letting me know that the bone did not completely mature. And so if you want to have good native bone, you want to use things that the body could use, because remember, the osteogenesis, osteoclast, and induction, all it's want to do, there's going to be a lot of turnover. That's why there's so many holes within the bone, because the bone builds and it takes away. Bone builds, takes away. Here's a little parallel. If you think about individuals who are taking bisphosphonates, you want to, like, if you take away that bone, it's really brittle, and there really aren't too many holes within it. And the reason why is because it has halted the process of bone building and bone breakdown. Bone building and bone breakdown. And so that's how individuals, when they have osteoporosis, they take that medication because it halts that clastic activity. So gave you a little pearl there. I kind of went a little long in this tip, but you know, at the end of the day, you know, it's going to be here forever, and hopefully sometime in your dental career you take advantage of this and you're able to smile after surgery. So all right, guys, I said a lot. I'm going to put these pictures up so that you can see them. Once again, if you really want to smile after surgery, it really starts with making sure that your patients are comfortable and you're able to get them numb. So all these tips mean absolutely nothing if you don't have the foundation of being able to work with your patients. So click the link down below. It's my free book. Once again, you're getting 100% free. I'm showing you exactly what I'm doing that's worked for thousands of patients. I can't say tens of thousands, but we're close to it. Tens of thousands of patients. And I just wanted to share this with you because if you're going to smile after surgery, especially with everything that's going on, you got to have some tools in your cap or feather cap or whatever. It doesn't matter. You get the point. All right, guys. So once again, like, subscribe. If you like this video, throw it down in the comments. If you did not like it and say, hey man, this is crap, let me know that as well. All I want to do is improve so that the world could smile after surgery. All right, guys. Once again, I'm Dr. Jared Williams, and my focus is for you to remember that what looks hard is often easy. Make it a great one.